We're here today to talk about major hemorrhage in children. My name is Matt Edwards. I'm one of the Paediatric Emergency Department consultants at King's. Will?
So good morning, I'm Will. I'm the Paediatric A&E Regis at King's as well.
And James?
Hi, I'm James. I'm one of the transfusion practitioners at King's.
Great. So we've got our challenges of the clinical aspects and the challenges of the lab-based aspects. So to start off with, what is the definition of major hemorrhage, James?
So there's a few technical definitions. So it can be the anticipated total blood loss within 24 hours. It can be a loss of 2 mils per kilogram per minute or a loss of 40 mils per kilogram within 3 hours.
What does that mean practically for you, Will, actually sort of looking at a patient and thinking, could this be major hemorrhage?
So the number's really helpful to know, but when you have a child in the resuscitation department who is bleeding, it's very challenging to know an exact amount of mils they've lost. So essentially, if you think they are showing signs of hypovolemia, with their tachycardic, hypotensive, and you think they're bleeding, so think early that maybe this child could be bleeding, we need to correct it.
Yeah, and I guess it's that projection, isn't it? And thinking that essentially this is going to be uncontrolled hemorrhage that we're unlikely to be able to sort out very quickly. Okay, so Will, what practically does the child who's bleeding look like?
So there should be some history of trauma, or normally is, and there could be profuse blood loss, but sometimes children can bleed internally, so you may not see the amount of blood loss. But if your child is hypertensive, tachycardic, prolonged cap refill, then think early that there could be some ongoing blood loss.
Is there a role for permissive hypotension as a strategy in child resuscitation?
So it's not something paediatrics that we're familiar with, and it's not something that we do, no.
No, and it's something we do in adults, and it may be something you do in the older teenager, who looks like an adult and is over 50 kilos, who we might be treating in that way. But for your smaller child, we wouldn't be doing that. So James, when the clinical team have decided that this patient is bleeding and that they need blood products sort of now, and they think it's going to be large, what practically happens in the lab? What do we need to do?
Yeah, so it's important that the clinical team activate the major hemorrhage protocol, and that will be different depending on which hospital you work. Generally, it involves dialing 2222. So it's important that the clinical team are aware of how to activate it properly. You'll need to speak to the laboratory and give them the patient information, the first name, last name, date of birth, hospital number. Patient weight will be useful for the laboratory as well, and then they can issue out products depending on the weight. And it's always very useful if there's a single communicator on the clinical side that's communicating with the same person on the laboratory side, just to ease that flow of communication.
Yeah, I think that's one of the areas that I find the most challenging, because this is going to be a critically ill child and there's going to be a lot of people involved. And so I think definitely, that allocating someone to be your liaison and keeping an eye on what blood products are going in is key. So, what kind of doses of blood products and things are you going to be practically giving?
So it's best to start at a small amount and then go up as needed. So start maybe with 5 to 10 mils per kilo aliquots of blood, red blood cells, and then if there are continued requirements for more products, then consider larger volumes. Starting low and then going high is very important.
So James, we think about the blood products that are coming in ratios, don't we, when we're thinking about a major hemorrhage. What does that mean?
So basically we're trying to replace the blood products as close as possible to whole blood. So we'll be aiming for a 1-to-1 ratio of red blood cells to plasma, but we also need to keep in mind platelet count as well. We're trying to keep the platelet count above 50 or above 100 if it's a cranial bleed.
Yeah.
And we also need to think about replacing fibrinogen, so the cryoprecipitate to replace the fibrinogen, and we're aiming to keep fibrinogen above 1 grams per litre.
Yeah, so one of the things is we just need to make sure that we're actually taking the bloods to be able to give that kind of information as well, which can be quite easily forgotten. Another thing that could be quite easily forgotten, and I think I have already forgotten it, is the tranexamic acid to be giving for the child who's bleeding as well, James. Yeah. So what that's come from the adult data, but we still think it works in children?
Yeah, so we often use it as a first line treatment. It's an antifibrinolytic, so it really helps assist to make that nice stable clot to stop the bleeding.
Yeah, so 15 mils per kilo for the child who you think is really bleeding, and give that in even before they have the blood products. So the blood is practically coming down in the different ratios, and someone's liaising with you about how much they're needing. It can be a bit risky to have a lot of blood products going into a child, isn't that right, Will?
Absolutely, yes. So you have a child who's already unwell, in a physiological insult before they come in, and you're giving them a large volume of blood, and this can cause fluid shifts and called fluid overload. It can also cause electrolyte abnormalities, giving you hyperkalemia, hypocalcemia, which needs aggressively checking and correcting. And in addition to this, blood can often be not as warm as the child, so a large volume of content can make them hypothermic, and then it'll worsen their outcomes. So really making sure the temperature's controlled, electrolytes are controlled as well, and reassessing to look for fluid shifts is really important.
Yeah. So James, from your perspective, you probably have heard of those cases whereby the child's had a lot of blood products and have ended up with quite a bad complications from that.
Yeah. The things we need to look out for transfusion-wise would be signs of reactions, as with any transfusion. But yeah, especially in paediatrics, we really need to think about fluid balances and looking out for signs of overload, of transfusion overload.
So it's really important to know when to start and start early, and then also when to stop. Okay. So wrapping it up then, guys, what do you think are the major key messages that you would want people to take away?
Good communication with the laboratory. And monitoring the ratios of the red cells to plasma, platelets and fibrinogen.
Yeah. And Will?
I think using your team well, so having someone assigned to organising the major hemorrhage and organising the blood, someone assigned to reassessing the child to look for side effects and look for response to treatment, and someone assigned to lines. So using your team well.
Okay, great. Thanks very much.
Thank you.
Perfect.